Welcome, everyone. I'm Dr. Carmen Puliafito, and we're pleased to have today on retina synthesis Professor Andre Witkin of the Tufts University School of Medicine, where he is director of the retina service. Andre also has an important role in the retina community in America because he is chairman of the REST Committee of the American Society of Retina Specialists. Welcome to Retina Synthesis, Andre.
Thanks, Carmen. It's a pleasure to be here.
So in July, there was a case report of retinal vasculitis following injection of Pegcetcoplan. And the REST Committee, which looks at adverse effects from retinal agents, gathered a series of cases, which you've presented at a number of meetings and recently published in the Journal of Vitreoretinal Diseases. Can you tell us a little bit about retinal vasculitis following anti-geographic atrophy complement inhibition?
Sure. So really most of the information we know is from the clinical trials. These trials are designed to look very carefully at safety events of the drugs over a long period of time. And in none of the clinical trials to date of any complement inhibitors have we seen inflammatory retinal vasculitis as a complication. So the drugs were approved, and at that time we weren't aware of any signs of that kind of problem. After the drug was approved, people started injecting it, and the ASRS has a mechanism by which people can report safety events. And starting in April, the REST Committee of the ASRS started to receive some adverse event reports, including cases of intraocular inflammation associated with Pegcetcoplan. And then, as you mentioned, starting in July, we began receiving reports of retinal vasculitis. And in that time period, over a couple weeks, there were several reports that the ASRS received. And because that was a new problem, and because we received several reports, the ASRS published a safety alert to the society members, and there was a lot of discussion in the community about that. And then soon after was the ASRS annual meeting, and I spoke at that meeting about the cases that we had received by that point. Since then, we continued to receive more reports, and we wanted to make sure we were really carefully analyzing the cases, because it's important that we clearly define what is retinal vasculitis and what isn't. And so we actually recruited some outside uveitis experts to look through the images alongside the members of the REST Committee, and we did a detailed analysis of the images from those cases, and that's what we most recently published. And it seems to, as far as we know, it seems to be a relatively rare side effect of Pegcetcoplan. In our series, there were 14 eyes that had the problem, and there's many thousands of people that have received the medication, so it's most likely a rare problem, but it is potentially a very serious problem that can be associated with that drug. Now, there was one case that we included in the publication where there was a patient with Stargardt's disease. They received Pegcetcoplan in one eye, and then they received the other FDA-approved drug, ACP, in the fellow eye 4 days later. And that patient ended up getting occlusive retinal vasculitis in both eyes. And as far as we can tell so far, that's the only report of retinal vasculitis associated with the other drug, ACP.
So what's the clinical profile of these cases?
There is a range in severity. Some cases had non-occlusive vasculitis where, the vision recovered fully. But of course, the cases we're most concerned about are ones that had severe vascular occlusion, and there are several eyes that did really, really badly. In fact, there were 2 patients, as far as we know, that were enucleated because they had such severe vascular occlusion and ended up getting new vascular glaucoma from that.
So all of these cases came from first injections. Is that correct?
Yeah, that's right. That's an interesting caveat with all the cases of vasculitis is that they all came after the first injection, which is a little bit different than the retinal vasculitis that we've seen with some of the other drugs, like with Beovu, for example, where it could happen after the first injection, but often you're seeing it after more than one injection.
So this has changed clinical practice because bilateral injection of initial therapy is probably not a great idea.
Yeah, absolutely. One of the recommendations that we talk about in the paper is that it's probably a good idea to wait at least 1 month after giving an injection to one eye before considering injecting the other eye, because all the cases of vasculitis occurred within a month. And so it's probably a good idea to wait a little bit before doing bilateral injections.
Any way of identifying eyes at particular risk for retinal vasculitis?
We looked at different risk factors like autoimmune disease or history of uveitis, and we didn't really find any particular association. There were a number of eyes, I believe there were 4 eyes that had a history of wet AMD that were concurrently receiving aflibercept for that. But there was actually a talk by Dr. McCumber at Angiogenesis where they looked through a large number of patients that were injected from the RCA group. And it seems like that may be just a reflection of the types of patients that are actually being injected in the real world. They had a large number of patients that had wet AMD in their series as well.
There was some speculation that the gauge of needle used to draw up the agent could have been implicated. Could you discuss that?
Yeah, there was a discussion that the needles may be causing inflammatory events. I think at the time that the company released that, they weren't sure if it was really related to vasculitis specifically or not. Since the needles have been pulled, we've still received reports of retinal vasculitis. There are 2 reports in our series where they occurred. There were fairly severe occlusive vasculitis that occurred after the 19 gauge needles were pulled. So it's still possible, even with the 18 gauge needle, whether that was associated or not, I think is still kind of up for debate, but certainly it can happen with the 18 gauge needle too.
What about suggestions for treatment?
That we have a fairly small series. We did look at the different ways that the patients were managed. It seems like steroids probably can play a role in decreasing inflammation, but it's unclear if they really change the outcomes in these patients. Despite aggressive steroids, there were still patients that had bad outcomes. But certainly that's something to consider. And it's also important to remember that intraocular infection can be a cause of inflammation and can even cause retinal vasculitis as well. So that's always on the differential diagnosis too. And certainly one can't be faulted to treat for infections endophthalmitis in these patients as a precaution.
So tap and inject is something that might be considered.
I think it's always worth considering if someone has a lot of inflammation after any kind of injection.
So what's the current status? We're now talking on the middle of February, and the paper was published in January and February, and we have a series of 14 cases. Any new cases popping up or not?
So I talked a little bit about this angiogenesis. We have to be a little bit careful about what we're calling vasculitis. Like I mentioned, we did a real careful analysis of the images, and that's a really important thing, is that we collect the images and really look at them and all come to a decision to call that vasculitis. So for right now, we're still receiving reports, and certainly we encourage people to continue to submit reports to the ASRS, because we still don't really know that much about this condition. But for now, I think the information we have is included in the paper. I don't know that we really know anything more than what's there at this moment.
So what's the diagnostic evaluation of these patients? What's recommended?
Well, imaging is really important. And if angiography is possible, that's a very good way to look for vascular involvement, especially wide field fluorescein angiography. Any patient that has significant intraocular inflammation is probably a good idea to consider an angiogram, because certainly there may be cases where you don't see any obvious retinal findings, where you may pick up some mild case of vasculitis. And I think it's important to do that because, it's possible that the vascular involvement may get much worse with a second injection, for example. And the reason I say that is the condition might be similar to vancomycin-associated retinal vascular occlusion, or HORV. And in those patients, there were a number of eyes that did significantly worse when they were given a second injection of vancomycin. So it's possible that this condition is similar to that. And I think it's really important to avoid injecting Pegcetcoplan again in those eyes that have vasculitis.
Well, this is an ongoing story, evolving, and it's good that things have seemed to have calmed down with this. Speculation on etiology.
Yeah, we talk about that fairly extensively in the paper. I think basically what we talk about there is a summary of possible etiologies. Like I mentioned, infection is a possible etiology. When you're inhibiting complement, you're suppressing part of the immune system, and certainly there's a theoretical increased risk of infection. And so that's one theory. I think there's a number of things that go against that, including the bilateral cases, and also the fact that it's a pretty unusual presentation for endophthalmitis. Another possibility is non-infectious inflammation, and that could be triggered by different kinds of antigens on the drug that might include the PEG portion of the drug. There's been reports of anti-PEG antibodies potentially causing inflammation from other systemic drugs. But the problem with that is the amount of anti-PEG antibodies in the general population is really high. There's a PEG in a lot of different things, including foods and hair gels and lots of different stuff. So I think it's going to be hard to parse out if that's really a cause or not. Anti-drug antibodies are a possibility. And then the last thing we talked about in the paper is there may be some actually drug mechanism related etiology. Blocking or complement deficiency rather is associated with lupus-like syndrome in people. And as we know, that can sometimes be associated with vascular occlusion or retinal vascular occlusion. And so that's another possible etiology, but that's just really speculation. All of these things are speculation. We really don't know what the etiology is at this time.
Well, we all appreciate in the retina community the great work that you and your colleagues have done, and this is the way things need to go. Thanks for your participation in retina synthesis, Andre.
No, thanks. I really appreciate your time. And again, just a plug for the ASRS, please continue to report to us. It's really important that we keep learning about this rare but very serious problem.
Thank you.
Thanks a lot. Take care. Bye.